This is the Myrna Method live stream. I'm registered dietitian Myrna Haag, and I'm here to give you some impactful nutrition information that will make a significant difference in your life. In this video, what we're going to talk about is lipo-a, and that's a gene marker because I'm on a little series of some gene markers that I highly recommend that most doctors know about. And knowing these gene markers can make a big difference in your life, knowing how to eat to alter the epigenetics, which we'll talk about that. Because genes express themselves in a certain environment, which would include the diet, can also include toxins in your environment, but genes do things that they shouldn't be doing, and we want to get them to do things that they should be doing. So in this video, we're going to talk about a certain gene called a lipo-a, and it's a gene that most doctors know about, and you can ask them to have you tested. So, Sammy, if you want to switch it over, let's start the little podcast. We'll get going on. Okay, are we showing it? Okay, great. So first of all, I want to talk about what is medical nutrition therapy. It's where registered dietitians look at all your clinical backgrounds, your biomarkers. We get a really good assessment, and we really look at the functionality of your food, of supplements, and how they can make a huge difference in your life. So it would be totally normal that a dietitian would be looking at certain genes and understanding how food can affect those genes. In this case, we're going to talk about the lipo-a. Also, just so that you know this, most people may not know this, but 75% of most diseases can be reversed with the right diet and lifestyle. So that's pretty huge, right? So I think it's worth talking about because in this case, we're going to look at genes that can be really significant in knowing. For you, I'm going to say the basic test most doctors do. For you guys are going to be the basic CBC, CMP, your lipid panel. Maybe you'll get your blood sugar testing, your vitamin D. These are kind of the standards. But some of the specialty tests that I do for genes, we talked about the APOE last podcast. Now what I want to talk about is the lipo-a gene. So let's get first talking about genes, because a lot of guys are going, all right, well, so what does that mean? What is a gene? So genes are found in the DNA, and it's your messaging center. This is when the DNA is getting a clump of proteins that are going to do certain instructions, are going to have certain functionality in the body. So you need genes to just about make everything, skin, hair, blood, everything has a gene print to do something for you in your body, these proteins that do this. So when we talk about genes, we talk about genes that can be changed by your environment. That's epigenetics. So the actual gene doesn't mutate itself. It just gets expressed a little differently based on what's going on in your life. So that's the epigenetics. And then we look at gene mutation. And this is when the actual gene actually mutates. This is not reversible with a gene mutation. That means the gene itself has been altered, the protein, and the DNA is not getting the right messaging. With gene epigenetics, it's when the gene hasn't been altered. The gene is not mutated, but it's being expressed in the body in a way that's not desirable. It's causing symptoms, maybe disease, but the gene itself is fine. It's just being expressed not in favor of what we'd like. So epigenetics refers to the way your behaviors and environment can cause changes that affect the way your genes work. Epigenetics turns the genes on, or that turns the genes off. So in this case, we want to understand about lipo-a, what is it, what are the risk factors involved, and most importantly, how does diet turn it off? So with the lipo-a, this gene is kind of like your LDL, which is your bad cholesterol. It's similar in chemical structure. It's got a little tail at the end of it that kind of makes it a little different than the actual LDL cholesterol, but it's a cholesterol that's very damaging. In fact, a lot of people don't even know they have this type of cholesterol, because when your doctor goes to do your cholesterol panel, he's going to definitely test the LDL, which are considered the bad cholesterols, the HDL, your triglycerides, but rarely do they ever look at the lipo(a). Now, you can have a gene that means you're going to make a lot of this lipo(a), and that's the problem. So we all have a little bit of lipo(a). The key is we want to make sure that our markers when we get our lab tests show that we don't have high levels of the lipo(a). So the lipo(a) is called the widowmaker because people don't know they have it. They don't know they're a carrier. But in many cases, it's the unexplained early age heart attacks. It can cause blood clotting. It's associated with calcification. It's a pro-inflammatory, pro-calcification type of oxidized lipid. So this is a more sticky kind of bad cholesterol. I think of it as kind of sticky because it gets more in that artery wall and causes more damage. And the key is you may not know you carry it. And I always like to tell the story about Oprah Winfrey's trainer, Bob Greene. He had a heart attack at the gym. He was in his early 50s, wrote many books on the paleo diet, which would have been not the best diet for a lipo(a) carrier. He didn't know he had it because probably...
Bob Harper.
Oh, Bob Harper. Okay, what did I say, Bob Greene?
Yeah.
Oh my gosh. Forget that. Scratch it. Thanks, Sammy. So what he found is that he had this carrier because they weren't testing it in the normal lipid panel, and this increased his risk for having a heart attack. You can have a normal lipid panel, and that's the one thing that I really want to get across, is it's an independent marker for cardiovascular disease. You're at 2 to 3 times the risk for heart disease and stroke, even with a normal cholesterol reading. You go to your doctor, he's like, your cholesterols look good, but you could have this genetic marker, which means that you are actually at greater risk. Now, if your cholesterols look really well and you're keeping those numbers down, and even if you are at a genetic risk because you have this marker, you're going to be in better shape, right? Because we're keeping our cholesterols low overall. But let's say your cholesterols are elevated and you have this marker in addition to that. That's where we're really going to see a lot of problems. Although it is an independent marker, so you can have very high levels of lipo(a) and still be at risk. But what I have found with my patients is that when I'm really working on maintaining their ideal body weight, getting that balanced diet, which we're going to talk about, lowering their LDLs, I do see a little bit of a decrease in lipo(a). And specifically, certain diets and supplement can drop it as much as 30%. And for a lot of my patients, it takes them right out of the danger zone and puts them into a normal level for lipo(a). So let's talk about the lipo(a) as a genetic factor and talk about heart attacks. So in this particular study, it talks about the genetic variation in the lipo(a) gene that increases this lipo(a) level that also increases coronary artery disease. The lipo(a) is the parental lipid protein carrier for oxidized phospholipids. So what that means, it is the preferred carrier of oxidized fats. And what are oxidized fats? Well, trans fats are a type of oxidized fats. A lot of these seed oils that I'm not a proponent of, they can create more of these oxidized fats. So fats become oxidized in the body. LDL, which are your bad cholesterols, become oxidized fats. Well, these particular lipo(a) are carriers of these oxidized fats. And when you have a lot of lipo(a), you have more carriers of pro-inflammatory oxidized fats. And what they do is that they cause damage in the endothelial cell. That's right in here. This is the wall of the artery. This is where the plaques begin to grow. And this is what happens with these lipo(a)s. It creates more of this plaque, more inflammation in the artery. So we go on talking a little bit about some more studies. And in this study, let me see if I get my pen to cooperate. Elevated lipo(a) is an independently associated cardiovascular disease marker. It has a strong link with cardiovascular disease, point blank. This particular biomarker, it exerts arthrogenic effect, and this is the plaque. So it increases the deposit's likelihood of plaque in your artery. Very pro-inflammatory. The key is you may not know you have it, so it's always good to go and get tested for it. What is the number one diet for a lipo(a)? It's going to be a plant-based diet. Now, I have the lipo(a), and I really didn't even understand what it was until I started doing the research, and I was working with some doctors that were actually testing for it, and I was really surprised that I had elevated levels of lipo(a). I was not a vegan before this, but once I got that marker and I saw that, and I have a family of a lot of heart disease. So I have a mother that had a stroke. My father had triple bypass before the age of 70. So I knew that I had a genetic marker that probably was responsible for a lot of my family history for cardiovascular disease. I definitely reduced my marker for lipo(a) once I was vegan. Now, I do talk in all my podcasts about what are some of the best diets and why. For this particular gene, a plant-based diet has shown to have the best lowering effect. Now, I'm big on lowering a lot of fats. I'm good at keeping your ideal body weight, losing weight, all of that. Well, that had actually no effect on the lipo(a). The biggest effect was actually reducing dairy and animal foods from your diet. So this particular study talked about a plant-based diet has a favorable impact on lipo(a), inflammatory indicators, and other atherogenic lipoproteins, which means other plaque-forming fat particles. The lipo(a) concentration was previously thought to be only minimally affected by dietary intervention, because I'm still looking at diets now, and I have a lot of doctors say, oh, well, diet can't affect lipo(a), and I'm here to tell you, as a dietitian, it definitely can. And I know it for myself personally, and I know it from working with patients as well, because it can actually help reduce inflammation. I do want to mention that just because you're on a vegan diet, there's still going to be an understanding how to do it correctly, right? Because we have to look at the macronutrients, which I'm going to also go over in this video. So let's continue on and see some more research about a vegan diet and how it reduced the lipo(a). So the reduction of lipo(a) was profound and is one of the largest reductions due to lifestyle reported in this particular literature, which is in this study that I pulled from. The magnitude of change was comparable to other leading medical therapies such as niacin, which can, and we'll talk about niacin, which can actually reduce lipo(a) by as much as 20 to 30%. And of course, some drugs, which I'm not going to talk about the drugs, that's not my scope of practice, but PCSK9 inhibitors, they have as much as a 25% reduction, and massive dosages of statins, which nobody wants to be on, but they have shown to also reduce the lipo(a). This particular study put people on a vegan diet for 4 weeks, and within 4 weeks, they saw a 16% reduction, which, by the way, if you're on niacin and some of these other drugs, you're lucky to get a 15% reduction over 3 months. And I do know this to be true because, hold on, let me get my pen here. Okay, I have a little, there we go. I'm not very good with the techie stuff. So it's 15% after 3 months. And some of these, this vegan diet shows 16% after only 4 weeks. So this to me was pretty significant, and I already knew this once I knew I had a lipo(a), that I was going to probably have to change the way I was eating if I wanted to live longer, right? So I'm 65, I want to make it to 105. So plant-based diet seemed like the most logical diet, which it did improve my Lp(a) and other patients that I put on the program as well. So I want to get across that when they did this particular study, what was the kind of diet that they had these people doing? 5 servings of fruits and vegetables, 5 servings of fruits, 8 servings of vegetables, which is a ton. They had a macronutrient diet that was anywhere from 15 to 20% protein. The carbs were anything from 40 to 50%, and fats were 35%. So they weren't really lowering the fats. And for the Lp(a), they didn't see as much of a significant reduction with a low-fat diet as much as they did when it was plant-based, managing those macronutrients. So that's what I'm going to bring you in this podcast, is what we have to do to get a decrease in the Lp(a). In this study, they also had the diet. They didn't do fried potatoes, dairy, meat, no refined grains. Those are like, chips or anything that's very high in processed food. They didn't do added oils, so you're not going to get the canola, not a lot of olive oils. They did not do animal fat, red or white meat, or eggs. So it was pretty much vegetables, fruits, grains, proteins from animal sources. So let's figure out, number one, how do we get this diet? What does this diet mean? Well, the biggest thing that I want to talk about is the macronutrient side of the diet, because this is an area that I talk a lot about. So I'm not like a proponent of, let's just go on a paleo, vegan, keto. I try to give information on each of those diets, what maybe some of their benefits are, if they have any, or maybe not. So with the vegan diet, I think that it's a really good anti-inflammatory diet. But if you don't get the macronutrients right on whatever diet, vegan or paleo, you're really not going to get the benefit from the foods you're eating, okay? Because I know there's a lot of health attributes with eating certain healthy foods. Like we go, vegetables are healthy for us. They have a lot of really good nutrients. But if you don't get this part of nutrition right, it's going to be a big problem. So let's talk about, how do we get the macronutrients right? Because a lot of people know what a macronutrient diet is, getting the right ratios of protein, fiber, carbs, and fat. But we're like, well, what does that mean? You say I got to have 20% protein. How do I figure that out? Well, the first thing you got to figure out before you can get your macronutrients you need for the day is you got to figure out how to get your ideal body weight. So I have a formula here. It's super simple, and let's go through it and we can do the math. So for women, the ideal body weight formula is for every inch over 5 feet, you add 5 pounds. So if you're 5'4", so if your height is 5'4", and you take away 5 feet and you've got 4 inches, you're going to multiply 4 inches times 5 pounds. And then you're going to add 100 pounds. So that's going to be 120 pounds is an ideal body weight for a person 5'4", but you can easily add 10 pounds and be well within your BMI. So the range is going to be 120 to 130 pounds is the ideal body weight for someone at 5'4". And for a male, all we're doing in that equation, same idea, but we're using 106 pounds as your base, and we're going to have it with 6 pounds for every inch over 5 feet. So if you're 5'10", then you have 10 inches. 10 times 6 is 60 plus 106. It's 106 to 176 would be the ideal body weight. So that's easy math. And why is that important? Because it's from this amount that we figure out our macronutrients. A lot of people say, well, is it 45% or 40% of your diet should be carbs? This is where it gets tricky. That's actually not correct. It's not based on what you're eating now. It's based on your ideal body weight. Because if we actually said that you were going to have 45% of the carbs of what you weigh now, it may be way too many carbs, right? So what we do is we take our ideal body weight, let's say for the female, it's 120 pounds. And we're going to use that when we talk about carbs and fats. The only one that we use our current weight for is protein, because you don't want to eat away any muscle mass you're hanging on to now. So you want to eat enough protein to maintain your current weight. So let's say your current weight is 150 pounds, or let's say 160 pounds. Well, you would divide that by 2, and that would mean that you need 80 grams of protein for the day. Now, we've got to eat this not at one meal. You want to eat it at least 2 to 3 times in the day. One meal is not a good idea because the body does better with protein to at least have 2 to 3 hits during the day. So if you know 80 grams is the minimum you need, that's the minimum. That's the minimum. We know we want to work on getting at least that. If you're on a plant-based diet, you want to add at least 20 grams. Let's put 20 to that figure. So if you're lipo-a, you're doing a plant-based diet, you've got to increase the protein a little more, because on a plant-based diet, even though the protein is the same quality as an animal-based diet, it's the same quality, the same amino acids, but they're not as bioavailable. So think of all those fibers the body's got to get to that protein too. And it's a little harder with a plant just to get to it. Once it's gotten to it, it's good as gold than it is with an animal. Only about 20 grams more. So a lot of the plant-based proteins may be maybe 75, 85% bioavailable, where animal proteins are more like 95 to 98% bioavailable. But that's no big deal, because to me, you just eat a little more protein. So that would give you an idea of how much protein you need. So how about the carbs? So you figure out your ideal body weight. Remember, we're not going to eat the amount of carbs we need for 160 pounds, because maybe we know we want to get to our ideal body weight of 120. So we take 120, and I just do it at the low end. So let me just do the math on this. I would take 120, and I would multiply it by 1.3. And that's going to give you 156 grams. You could round it to 160. And that's going to give you a pretty good average for your ideal body weight. This means your muscles would like to have 160 grams of carbs. A lot of people don't think carbs are a good thing, and I'm here to tell you a macronutrient diet is how you balance the diet and get yourself to a homeostasis, which is what I talk about in my course when I teach you how to eat right. So for fats, we divide by 3. So if we take 120 and we divide that by 3, then what we're going to have is 40 grams. Now, 40 grams is at the 25% range, and you want to have your fats anywhere from 25 to 35. So you can easily add 20 grams to that, and you could have 60. So in this study, they actually did it where the fats were at the higher end. I don't know why, but that's just particularly what they found, because they didn't find with the lipo-a that really cutting all the fats made a difference. Now, I do want to tell you that managing your fats do make a huge difference for diabetes. It makes a huge difference for other lipids, because having excess fats, you do increase your cholesterols. Absolutely. So, as a dietitian, what do you think I'm going to recommend? Anywhere from 25 to 35% fats is really going to be the golden ticket with these macronutrients, managing these fats. So that was an important part of this, is understanding that the macronutrient diet, super important, because this is a big part of nutrition. Then what we're going to look at is, how about the supplementation part of it? Well, what we found is niacin, which is a B vitamin, can actually be an effective treatment for reducing the lipo-a levels. And niacin can reduce it up to 20%, which is actually as much as some of these drugs, 20 to 30%. But the problem with niacin is you do have to take in excess. So you're really taking a lot of a vitamin, over 1,000% of its recommended daily allowance, which in some ways becomes a drug. When you take a supplement like that in these excess dosages, it's a drug. in a way. It's a byproduct of the body's got to clean it. So I have looked at some studies and I've thought, what's the lowest amount that I've seen that we can make an impact with lipo-a? And what I found is lipo-a works really well in some and not so well in others. And there could be a reason for this because there can be different variations of the lipo-a, which they don't test for the different variations. But we do know from reading some of these medical journals that deal with the lipo-a that this can definitely mean that you have some that will respond very well with the niacin therapy and some that won't. And I pulled up a case study and one person here that I just wanted to see what different levels. I'd like to always bring case studies. And this talks about a 62-year-old male with a past medical history of cardiovascular disease, elevated calcium score of 254, and an elevated lipo-a. Calcium score is when the plaque in the arteries becomes calcified. Now, it's hard as a rock. It's not going to be moving, but it narrows those arteries because you got to think of that plaque in that artery wall getting calcified, kind of like stone. Well, if you're a lipo-a, you're going to have a higher risk of calcification. This isn't so great because we don't want those arteries to get narrowed. So this is what we saw with the 60-year-old male, is that he had a history of cardiovascular disease and he had elevated calcium score. Patients presented to the cardiologist's office to establish care at that time that his lipo-a, when they measured it, was 325, which we want to have that lipo-a under 30, just to give you an example. And he wasn't on any statins at the time, so they started him on a high dose of statins, and 6 months later, they repeated the test, and they found out his lipo-a went down from 325 to 313, which is a 3.9% reduction using high dosages of statin for 6 months. And then the patient was started on niacin, 500 milligrams daily for 5 months later. And his lipo-a levels significantly reduced to 115. So he went from 325 when he started, went on statin therapy, dropped it to 313, and then went on niacin therapy and dropped it down to 115. Now, I will tell you with some of my patients, I do see some of these great reductions, and then with some of them, I don't. So currently, this actually talks about what I've discovered with patients, is that currently there's a debate in the literature that niacin decreases lipo-a by 20% in a dosage-dependent manner, which means that it does vary on the dosage, and it can be anywhere from 500 milligrams to 1,500 milligrams. With some patients, I only need the 500 milligrams. For many other patients, I need to bump it up to the 1,500 milligrams. However, it remains unclear, they state in the study, as to why niacin is effective in some patients and ineffective in others. So recent studies have shown that the reduction of this lipo-a by niacin could be related to the different isoform size. So we're already seeing that lipo-a, the gene, can have different variations, and this can affect the results of using the nicotinic acid. So niacin comes in many forms, and the type of niacin that you want to use for the lipo-a is the nicotinic acid, okay? And I put Endursin. This is the one I typically use that I've gotten good results with patients on. It starts at 500 milligrams. I would start on that. I have seen results with just 500 milligrams. 1 gram, which is 1,000 milligrams, I definitely get results. Not necessarily do you have to increase it from 1,000 milligrams to 2,000, because you can get results on 1,000 milligrams. And you can get tested. It's not an expensive test. I think a lipo-a test is $17 or $20. So it's not that major big expense. Good to know. So bottom line, if we're trying to really change and alter the epigenetics of this gene if we don't want it to express in a negative manner, which means causing sticky plaque, increasing blood clots, increasing a pro-inflammatory condition in your arteries, increasing calcification, so you're going to be more prone to a elevated calcium score, then we definitely want to stay on that macronutrient diet. We want to make sure we get enough protein, which is super important. We do want carbs in our diet, and we want to make sure that we get a lot of fiber, because one of the studies they talked about with plant-based, because typically that's what plant-based is going to have, is a lot of fiber. You're going to be getting a lot of plants. And we want to bring in the nicotinic acid. So both the plant-based diet and the nicotinic acid can reduce the lipo(a) by as much as 20 to 30%, okay? And in that one case study, we saw an increase of 60% just with the nicotinic acid alone. Now, if you have the lipo(a), what I have found with my patients is I'm also wanting to reduce risk factors for cardiovascular disease, because they already have a huge risk factor when they have the lipo(a). It's already there, right? So we already know they have a genetic predisposition. So we know when I see a patient with a lipo(a), I am really, really working on reducing other risk factors for cardiovascular disease, because I don't want the other cholesterols elevated. And what's going to be the major ticket there? Once again, macronutrient diet, recommending those fats between 25 and 35%. I have not seen good results with really these elevated fats. Cholesterols are elevated every single time. When I see patients go from a 25 to 35% fat diet to a 40 to 45% or even a ketogenic diet, I'm seeing elevated cholesterols, period. So until I really get enough studies to tell me that's not a problem, a few people say, oh, well, it's not a problem to have elevated LDLs, I'm still sticking with the science that I got. And what I'm showing is that elevated cholesterols are a problem. LDLs, these bad cholesterols. And this lipo(a) is definitely in the family. And you may not know you have this gene. Approximately 20 to 25% of the population has this gene, doesn't know it. So you could be going to your doctors and having maybe your cholesterol is elevated a little bit, but nothing to be concerned about. But then if you also have this genetic marker with a cholesterol lipid panel that is kind of borderline, you're going to be at 2 to 3 times greater risk just because of this genetic marker. So the key is I want to keep my bad cholesterols down, I want to exercise, and most importantly, you want to maintain your ideal body weight. If I had to pick one factor for overall health, it's to maintain your ideal body weight. Now, as far as maintaining your ideal body weight, I'm going to give myself a little plug, Sam, because I think we have it up here. I have a course I teach. I have a membership. I teach people how to balance these macronutrients, how to do what I call keeping this homeostasis, this balance. A lot of people think a balanced diet, I just got to eat from the 4 basic food groups. The balanced diet has to do with keeping the ratio of those macronutrients at a certain amount daily, which I just gave you, but also at each meal, and how that synergy works. It creates a homeostasis, and you can literally reduce your appetite, because that's the key with maintaining an ideal body weight, not to trigger the appetite. High protein, high fiber foods, they are your biggest appetite suppressors. But you have to understand how carbs work. A lot of people want to eliminate them, but you have to know how to balance them. That's going to be the ticket. If you go on a really low carbohydrate diet, it might seem like the magic bullet, but there's other implications in regards to that it's not sustainable. And there's a really good reason biochemically why. So I wanted to leave it open for questions on the lipo(a) or even questions in general on diet that you guys may have. Just go to the chat. I'm here for you. And Sammy's going to get that up and running.
Nope, nothing in chat today.
Okay, awesome. Okay, guys, thank you. And I appreciate it. Don't forget to like. Don't forget to subscribe. We're almost at 500. Awesome. Thank you. I appreciate it. And until next time, thank you. This is registered dietitian Myrna Haag.